Hi guys, it's Professor Costa, and today we're going to be talking about care of patients with obesity and obesity surgery. I don't think there's any surprise to anyone who's worked in a healthcare facility in the last decade that the incidence of morbid obesity has increased exponentially. We have so many patients now that require special lift equipment, jacks on their toilets, larger bariatric beds, and more people are opting for obesity surgery. So obesity is an excess of adipose tissue in the body. It's one of the most prevalent preventable health problems in the United States. There are so many people that die from the effects of obesity in the United States. It's just a shame. It has serious physiologic and psychologic consequences and is associated with increased morbidity or mortality. No surprises there. We all know that. It increases your risks for so many comorbidities. So we're going to learn how to do an assessment, and we're going to talk about non-medical drug therapy and surgical management of obesity. So I really hate this formula, this table, because I always come away feeling really bad about myself. But you'll see that it does not take something into effect. It does not take into account that people with higher muscle body content, like weightlifters, that it doesn't take that into effect. All it does is take your weight in pounds and your height in inches, and it calculates the BMI. So if you're in the yellow or red zone, you're overweight or obese. And I hate that I always come out. Actually, I've graduated from obese to just the overweight category. Woot, woot. But it's really disheartening when you realize that you yourself are in the high risk category. So obesity, it has reached epidemic proportions, especially in developed countries. So, and unfortunately, there is a racial disparity that people who are Hispanic or Black are more likely to be overweight. And a lot of that has to do with education, access to healthier foods, the cost of fast food versus a healthy diet. Unfortunately, 1/3 of the US population is obese. And 66% of those over age 20 are either overweight or obese. And of course, some racial groups have way higher percentages. It is the second leading cause of preventable death and the third leading reason for liver transplantation. I don't know how many of you know this, but fatty liver disease doesn't just happen with alcohol consumption. So we have something called non-alcoholic fatty liver disease, something that I was very surprised about. I had to have abdominal surgery, and one of the things they did is they took out my gallbladder while they were in there, and they took a look around, and they said, by the way, you have pretty significant non-alcoholic fatty liver disease, because they knew I'm not a drinker. And that was one thing I was always careful about. I'm Irish ancestry, and I'd watched a lot of people in my father's family succumb to, diseases that probably weren't helped by their alcohol consumption. So I had always been really careful about not imbibing. And then here I am doing the same exact thing, but with food. So that really was a wake-up call to me. So remember that obesity is the third leading reason for liver transplantation. Yes, drinking is, way higher up there, but you can do just as much damage to your liver and end up with cirrhosis because you're overweight. So etiology and pathophys. So people go back and forth with this. There's a lot of science in, both directions here. Is it familial in terms of, is it a genetic predisposition? And there is strong evidence of that, but it's really hard to separate environment from genetics when you're dealing with family groups, right? So it does cause significant genetic, biologic susceptibility factors, blah, blah, blah. So they think that there's a strong link between your genes and whether or not you have the predisposition to be overweight. But we all know that environment makes a difference. So you can have the predisposition to be thin, and if you're surrounded by people that show you different ways to eat, or maybe you were a thin person and you got married to someone who loves to cook and feed, and you can see how our environment does also affect this. All right, so caloric consumption must exceed energy expenditure for the condition to continue. So you'll hear that old story where people were athletes in high school and they were able to eat, and their energy expenditure exceeded what they, or matched what they were eating, so they were able to maintain a healthy weight. Well, then college comes, or nursing school, and we don't change our eating habits, but our energy expenditure definitely changes. And this is also why people, as they get a little bit older, tend to put on more weight. Hormonal differences do make a difference for women. It changes how well we store muscle. Also, if you have less muscle mass, you have a less basal metabolic rate. And if you don't change your calories consumed or add additional exercise, you will be predisposed to add weight. Okay? So appetite is influenced by many factors that are integrated by the brain. So our brain does, tell us if we're full. And it's most importantly from the hypothalamus. Now, why is this slide in here? And you're like, oh no, I hate this slide. Yes, it's here because some of the medications we give patients affect this response, and some of the obesity surgeries affect how our body, our stomach, or our intestines communicate with the brain. So it really does make a difference. So understand that we have leptin, PYY, ghrelin, and insulin are all affected by some of the things that we do. It's amazing what happens to insulin when we have patients who've had obesity surgery. You're dumbfounded when you look at the results. All right, so classification of body weight and obesity. So waist circumference, waist to hip ratio, and body shape or fat distribution. So we have the gynoid, or the pear-shaped, and we have the apple-shaped, which is the android. The android type, if you're carrying most of your weight in your abdomen, this does have an increased risk for cardiovascular disease. So body shape does make a difference. In some countries now, especially in Asia, they have preferred waist circumference measurements for men, and that's part of their annual, they don't just weigh them, but they take a waist circumference, and that tells them what they're at risk for if they need to be placed on some kind of nutritional changes. So this is an old slide. I couldn't find a slide that I liked as much as this, so I just kept using it. So all of the things that health risk associated with obesity, and I added to it, that little skin on the side wasn't even in the original textbook. So psychologic, just being overweight in a beauty obsessed Instagram, Facebook, picture, centric society can make people feel really bad about themselves. Depression, low self-esteem, risk of suicide, and discrimination. Well, being obese is one of the few, I don't want to say minority, but it's one of the few groups that still, it seems to be okay with a lot of people to fat shame or to give people tips on weight loss. It's still, people can still walk up to someone and say, oh, you should try this diet, or you should exercise, or you would look so good except you're fat. It seems to be okay to discriminate against someone about their body weight. We know metabolic. Type 2 diabetes, one of the leading causes of type 2 diabetes is obesity. Metabolic syndrome, we adding that insulin resistance, and then we're adding in all the fats and junk that come along with that. Polycystic ovary disease, also increases your risk of being obese, and obesity increases your risk of developing polycystic ovaries. Respiratory. So obstructive sleep apnea is a huge issue with patients in the obese category. And the reason why is when you take a breath, your diaphragm has to contract. And if you're laying flat especially, it has to push against the girth of your pannus or your stomach. So you can see why carrying the weight, especially in your abdomen, increases the risk for obstructive sleep apnea. asthma, and pulmonary hypertension are all increased when you have obesity. Reproductive changes. So adipose tissue has higher levels of estrogen in it. So it can cause menstrual irregularities, infertility, gestational diabetes, and overdue births, induced labors, and longer labors. So definitely some reproductive rates in there. For men, you can have hypogonadism, which is where your testes are smaller. Again, the reason for this is because, again, adipose tissue has higher levels of estrogen in it. And therefore, you can get gynecomastia, which is that female appearing breasts in a male patient. Musculoskeletal, I feel the effects of this all the time. I have wrecked my knees and hips and shoulders from years of being obese. And so osteoarthritis, impaired mobility and flexibility, gout from, increased junk that we eat, lumbar disc disease, and chronic low back pain. Ugh. If I had gone back, I wish I could have gone back 25 years and lost the weight then, but I didn't. I lost a lot. If you didn't know me 5 years ago, and I know most of you haven't met me yet, but add 130 pounds to my already large frame, and I was huge. Cardiovascular, hyperlipidemia. So, if you have impaired insulin resistance and you're eating garbage, then you're going to have high cholesterol. Sudden cardiac death, right-sided heart failure, left ventricular hypertrophy, coronary artery disease, DVT, AFib, hypertension, cardiomyopathy, and venous stasis, all of which are added. The risk for that is added just because of your weight. Liver and gallbladder disease, so the non-alcoholic steatohepatitis or the non-alcoholic fatty liver disease, yep, and gallstones, right? If we're not eating correct amounts of fat and our body has to deal with that fat that we're ingesting, it's going to affect our liver and it's going to affect our gallbladder. Genitourinary, so believe it or not, end-stage renal disease, secondary to diabetes and hypertension, and stress incontinence, right? You have so much weight, your bladder is a muscle or has muscles in its, what do you think it's going to happen if you throw 500 pounds on top of a balloon filled with fluid? It's gonna leak. Cancer, endometrial, breast, cervical, ovarian, uterine, gallbladder cancer in women, colorectal cancer in both genders, and prostate cancer in men. And then I added the skin on the side. So many obese patients experience localized bacterial or yeast infections, irritations in their skin under the skin folds, especially under the pannus, which is that where your stomach hangs over your belt there, or over your groin, in the groin and under the breasts in both sexes, and in some cases even in their armpits. So this is what I'm talking about. See, she's lifting her pannus here, and that area in morbidly obese patients, they have a scent to them. No matter how much they shower, if you have sweaty skin touching itself over time, it's going to develop a smell. And so even though most of these, now this lady looks well groomed, right? Look at her nails. She's got nice rings on. She doesn't look dirty, but they develop fungal and bacterial infections in those folds. So a lot of these people are told to bathe, and then they're going to add a powder, oftentimes with a nice statin in it, to prevent fungal infections in those folds. So our nursing assessment, we're going to do a thorough health history, time of obesity onset. Do you have any diseases related to metabolism and obesity? So have you already been diagnosed with something like diabetes, or have you been diagnosed with polycystic ovarian syndrome? What medications do you take? And this is really important, especially with our psych patients. Remember, a lot of the antipsychotics and antidepressants can cause weight gain. So if it's something like a medication cause, perhaps we can deal with the psychiatrist, or maybe change meds, or maybe do more teaching with the patient that, yes, this medication will predispose you to gain weight. This is what we need to do. So they're going to do a height and a weight, calculate a BMI, some skin fold thickness, waist circumference. In some nutritionist office, they also have the scales that actually measure your percentage of body fat and your muscle and so forth. History with weight gain and weight loss. A lot of people who are overweight do actively try to lose weight, and they can end up seesawing, going back and forth. Are you interested in losing weight? Are there any contributors to weight gain? Well, yes, my husband is a chef at Greg's and makes all the cakes, and he brings one home for me every day. Or have you been divorced? Or have you noticed that you're gaining weight after menopause? Or did you gain weight with child birth and so forth? What impedes your weight loss? Is it that you're not active? Do you need a knee replacement, and that's what's keeping you from walking every day? So what are the things that are impeding an optimal weight? How the patient uses food. Now, this is one of the things I did all the time. I was an emotional eater. So if I was happy, I ate. If I was sad, I ate. If I was bored, I ate. I love food. So, how the patient uses food. Do they have other overweight family members? How hard is it to lose weight when you're eating celery sticks and everyone else in the family is eating Twinkies? Ugh. And are there environmental or genetic factors in influencing weight gain? Something else too is not to forget the role of metabolism. So part of the assessment for this is we're going to be checking thyroid function as well, and make sure that the patient has normal thyroid function. Sometimes it really is a medical issue, and if the patient is augmented with levothyroxine, perhaps that fixes the problem. So planning. So this is even if, okay, you do the surgical option, or you found out that you had hypothyroid and you just needed to be added with some levothyroxine, it isn't a magic wand. You're not suddenly going to lose weight. So even with severe interventions like surgery, you still need a multi-pronged approach to pay attention to multiple factors: dietary intake, physical activity, behavior modification, and that sometimes it's just rethinking how you think about food, or making sure you write everything down. Even that small act often will help people achieve their goals, and or drug therapy, right? We're going to set a realistic and healthy goal for weight loss. We don't want you losing 20 pounds per week. I don't know if anyone's watched those shows like The Biggest Loser, and these people lose all this weight every week, and then you see them a year later and they've put most of the weight back on. So 1 to 2 pounds per week for an average size healthy adult is a good goal. We also have to prepare people that there's something called a plateau. So your body naturally wants to store fat to keep us alive. So we have to kind of give it its space to breathe. So you might lose really well 1 week, plateau, and not lose for a few weeks, and then start losing again. And patients or clients need to be prepared for when that happens. People get very discouraged and they want the results now. And you have to prepare them that there will absolutely be periods of plateau. Exercise should be done daily for 30 minutes to an hour, right? So if now anyone can exercise. The how strenuous their exercises are going to be is based on their weight, their otherwise, their health otherwise. So if you have severe CHF and the doctor wants you to lose weight, we're not going to have you do that, those severe, like running up the steps of the Empire State Building kind of stuff. But you can still exercise. We're going to get you with someone that will, cater to your needs. Maybe your exercise is only going to be moving your arms and legs in a chair, and then you're going to build up endurance. But just because you have severe disease doesn't mean you can't do something, right? Even a gentle walk, if tolerated, is still better than sitting in a chair. For people who, don't have physical limitations other than their obesity, they're going to build up as they lose weight. But nice things like walking, swimming, cycling, swimming especially, or the exercise classes in water are nice for the severely obese because they don't have to deal. It helps with the weight distribution, and they can actually do a lot more while they're in the pool and still burn some calories, and have some fun. So nursing implementation. So we're supervising a plan, right? So successful weight loss requiring a short-term energy deficit, successful weight control requiring long-term behavior changes, right? So we want people to get to an optimum weight, and then we want to teach them how to stay at that weight, right? Just because you hit the magic number on your scale doesn't mean, woo, I'm all done with my diet, and off I go, and I go to Dairy Queen and I get, the double fudge, peanut butter parfait, which is so good, but I can't do that anymore. All right. So multi-pronged approach ought to be used with attention to multiple factors. So dietary intake, physical activity, behavior modification, and/or drug therapy. I know I repeated myself, but you need to understand that it takes a village. All right. And people may need multiple things. They may need a MyFitnessPal app, and they may need to go to Overeaters Anonymous or Weight Watchers, or they may need to have a group of friends that do it with them. They may need to go to, behavioral health and talk about why they're using food in that way. All right. So it isn't just the person. It takes a village to help people lose that much weight. So nutrition, the easiest, not easiest, I should say. So it's calories in versus calories out. Well, if you reduce the calories in, most people lose weight. So diet classifications, 800 to 1200 calories is low calorie, less than 800 calories is very low calorie. And we're going to talk about fruits and vegetables, lean meat, fish and eggs, and vitamin supplements. And here's, some well-known industry, Weight Watchers. I forget, Oprah bought it, and I don't know if it's Weight Watchers or WW. Anyway, and Jenny Craig, okay? Behavior modifications. Again, like I said, sometimes it's just as simple as keeping a food diary and understanding that this is what I ate and this is what happened right before I ate it. Helps eliminate cues that precipitate eating. I know that if I watch the Great British Baking Show on TV, that I'm going to want to eat something on that show. I know it. So and I love the show. Don't get me wrong, I love me some Paul Hollywood, but I know that I need to eat a healthy dinner before I watch the show. It's that simple. All right. So social support groups such as Weight Watchers, Overeaters Anonymous, and Take Off Pounds, TOPS, and those are some peer support, right? And don't forget that some people do need to deal with a therapist about their relationship with food. I've taken care of patients, and I know people that have had weight loss surgery, and something that they went through, because when you have weight loss surgery, that is a permanent change to your body, that they went through the grieving process because they realized that they weren't ever going to have the same relationship with food again. And it was they had real feelings about it. So drug therapy, and let me say this is short term. You are not going to stay on drug therapy long term. All right. So we have phentermine, diethylpropion, and bendimethrazine. Caffeine. So a lot of over the counter. It's been a while since I've been to the aisle at Walgreens, but there's a whole aisle full of appetite suppressants, and most of the over the counter products contain caffeine. So save yourself a little bit of money, and if you want something that's a little bit of an appetite suppressant, have some tea or coffee. Remember, these are CNS stimulants recommended for short-term use. You do not want to use these long-term. I'll apologize. You can probably hear my cat in the background. She's being a brat. Okay, so here's some long-term ones that, and I'm trying to remember, probably should have checked before we started this lecture. One of these is off the market. Okay, so I'm trying to remember which one, but whichever one's off the market, cross it off on your slide. I'll let you guys, adult learners, Google that, all right? But there are some medications that affect how we metabolize what we intake, okay? And this one is Ally, which is orlistat, and it works by blocking fat breakdown and absorption in the intestine. So if you eat a high fat food, like, I don't know, potato chips or something, and you take this medication with the meal, it blocks some of your ability to absorb fat. Well, if you don't absorb it, you're going to poop it out. And this is what causes steatorrhea. So if you poop out fat, which normally we don't poop out much fat, our body absorbs it because, we use fat to make all types of things. You'll see the little globules of almost like at the top of not to gross you out, but the top of a vegetable soup with a little bit of oils floating around. That's what you're going to see in the toilet. Ally is sold over the counter, and you can get higher doses available by prescription. So if you eat a high-fat food and you take this product, you are going to have diarrhea. And not only just diarrhea, but steatorrhea. You're going to get fatty, greasy, smelly poop. All right, so bariatric surgery. When I say that there is a checklist for this, there is a checklist. You think your clinical skills checklists and things are full of stuff to do, or getting into the nursing program, you should see what these patients have to do to have bariatric surgery. First, you have to meet a certain BMI. So for most, and I'm just saying this most, there's different, depends on how many comorbidities the patient has, but for insurance to cover these, they have to demonstrate that they're usually a BMI of 40 or higher, and that's with no comorbidity. So a BMI of 40, so they're really overweight, but they don't have anything else like diabetes or, degenerative disc disease or whatever. 35 if they have something else on top of the obesity. So they're overweight, maybe not as big as the other folks, but they're still overweight at 35 or greater BMI, and they have something else going on, some complication due to the fact that they're obese. All right. And for some of the lap bands and the band, it may be as low as 30 with comorbidities, but each facility and insurance company has their own criteria. So there's three broad categories. There's restrictive, there's malabsorptive, and there's a combination of both. So restrictive surgeries, so actually physically restricting the size of the stomach. So if the stomach pouch or the stomach is smaller, you will ingest less and you will not eat as much. That's really the science behind it. So we have vertical banded gastroplasty, we have gastric banding, which like the lap band, and we have the vertical sleeve gastrectomy. Now you can see that the least invasive of these is the gastric banding. But that person, see that self-sealing reservoir under B? That's an external port that the physician can add or subtract fluid from the band by inserting a needle into the port. So remember, if we're putting something foreign inside of a person that's going to stay there, that increases your risk of infection at that site. Remember, body protects itself. So if it's not something that you were born with or that you made yourself in your body doesn't protect it, it doesn't patrol it. So the band could be a source of infection, and that self-sealing reservoir port could be a source of infection. Especially the polypropylene band with the calibrated stoma in the gastroplasty, same thing. If we're leaving something extra inside of you, that can become colonized with bacteria because it's a free place for them to stay without patrols, and you are at risk for an infection. A vertical sleeve gastrectomy takes a huge portion of your stomach and surgically removes it. The suture line is huge. So this is a much riskier surgery in terms of possible complications. You can have bleeding, you can have ulcer formation, and anytime that we surgically remove parts of your GI tract, you're at risk for something called dumping syndrome. We'll go over that too. Okay. Malabsorptive surgeries, like this one, this is the big malabsorptive surgery. This is for the really, 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 really high BMIs, okay? Like if you've ever watched that show, My 600-Pound Life, this is the type of surgery we're talking about. So what this is a biliopancreatic diversion with a duodenal switch. So they're removing parts of the the stomach. So they're making a pouch out of the stomach, and then they're rerouting some of the intestines around. And it also includes playing with the order of the how our gallbladder communicates with the duodenum, and this one's not done as much, but it is the most malabsorptive, meaning it really limits what the patient, if they eat something, whether or not they're going to absorb it enough. All right, so this does lead to lots of weight loss, but it also has higher complication rate, a much higher risk for, bleeding, a much higher risk of an intestinal infection. Just think we're cutting and pasting parts of your intestine. So the more that we do that and the more we manipulate it, these patients can end up with an ileus or a bowel obstruction very easily. All right. And most of them end up with some kind of absorptive disorder where they're not absorbing enough of certain nutrients. Okay, so the one that you really want to know which is a combination of restrictive and malabsorptive surgeries, is the Roux-en-Y gastric bypass, or also known as gastric bypass surgery. So this is the most common type of patient that you'll come across. It's the most popular surgery. It has a really high success rate. It's a nice combination with the restriction and not too much malabsorption, as in the switch that we went over in the earlier slide. So what this does is they make a pouch out of the stomach, and they don't remove that portion of the stomach. That portion of the stomach stays. The limb of the jejunum comes up and is attached to the pouch. So the pancreatic enzymes and all that eventually meet further down, and some of your digestive enzymes still continue to be made in the stomach, but they kind of meet up later on in the digestive process. So nursing care of the bariatric patient, possible complications. So we're always using this, but number one priority is airway management, right? So just being immobile for a period of time puts every patient at risk for DVT, pulmonary emboli, right? And this does vary depend on the type of surgery chosen. If we have some absorption issues added on purpose, like with the switch or gastric bypass, these patients may end up with anemia. So a lot of these patients are placed on B vitamin supplementation. Sometimes they even need injections, and iron supplementation. Vitamin deficiencies are a huge problem, and that it does vary on type of surgery performed. So most of these patients are on a vitamin regimen. Diarrhea. So if we've played with how your body absorbs certain fats, or we've rerouted your intestines at all, some of those enzymes that normally meet up with our food are diverted further down into the tract, and it predisposes these patients for dumping syndrome. So if they eat high sugar foods, or they eat high fat foods, or they eat foods that are both, like ice cream or cake, they're going to dump and they get diarrhea. We've finagled with the gut, so peptic ulcer formation often happens, so sometimes patients are placed on a PPI for an extended period of time. Dumping syndrome, which we'll go over in another slide. Small bowel obstructions, just from the healing process, the remodeling that takes place, and scar tissue formation, or a leak from the reanastomosis. Psychiatric problems. Remember what I said about how I've met people who've undergone this surgery and they go through a grieving process with food? Yes, that's absolutely true. And also it can change the person's role in the family. It changes their body image. Someone that was, maybe the spouse was a feeder that likes to feed, her husband and make him overweight, and then he loses weight, and that's going to change their dynamic. A lot of divorces come out of this. People go through huge transformations, and then they're not in the same relationship anymore. Also, alcohol is bad. It's bad for these patients. Patients need to stop drinking alcohol for immediate post-op period and for at least 6 months. Alcohol poisoning is a huge risk. they're changing the flow of your GI tract, and that affects alcohol absorption. So most of these patients who've undergone bariatric surgery are what I would call a cheap drunk. And, they may have been able to tolerate, a certain beverage. Not anymore. Their body is different, and they need to stay away from alcohol for at least 6 months, let their body heal. And then if they do some surgeons will say to their patients, never drink again. And, in a realistic world, if they do opt to imbibe, then they need to be very, very careful and prudent with it. So here is dumping syndrome. You need to know this slide, not only for our exam. It always shows up on either the HESI MedSurg or the EXIT or the NCLEX. It is so prevalent nowadays. So many people are undergoing surgeries for this. You need to know dumping syndrome. Anytime we do surgery on the stomach or, small intestine, and we reroute things or take things out or move stuff around, the patient is at risk for dumping syndrome. So they can end up with weakness, dizziness, diaphoresis. They say they feel like they're gonna die, like a severe horror. It's not I don't feel well. It's I feel like I'm gonna die. I need to lay down, right? Tachycardia, abdominal cramping. It is self-limiting, so even though they feel like they're gonna die, usually they don't. So it happens when they eat high fat or high sugar content foods. So they also don't want to push the food through faster. So they're taught not to drink fluids with their meals. A sip of water, okay, but you're not going to drink a huge glass of water with your food because that's going to just push things through faster and lead to dumping. So no fluids with meals. Salt, so-so, but no high carbs, so no breads or potatoes, and low fat. They do not want fat. So diet guidelines post-op is low fat, low carb, low salt, high protein, no fluids with meals. And they have to chew very carefully and swallow and take their time eating their food, especially in the first few weeks after surgery while their stomach and or intestines are healing from this. A lot of patients go home following bariatric surgery either on a liquid like diet or a pureed diet where they can have a little bit of scrambled egg, or some patients go home on a full liquid diet, which is those yucky nutritional shakes. So let's think about caring for our obese patients. If we were having this class in person, I would tell you my personal story about why I decided to lose 130 pounds. And I was at a huge amusement park in Florida, Universal, and they have this fabulous roller coaster called the Hulk, or they did. And I had waited in line with my kids for hours just to get into this stupid thing. And then I go to get on the ride, and I'm too big. I won't fit. So the guy stands to the side, and he's like, hold the ride, with his hands up, waving like an air traffic controller. And everyone turns to look, and they removed me and my kids from that row and had to stand to the side. They refilled the seat, and then we got on the next one. They walked me over to the obese, ride chair, and 2 people buckled me in. My kids were mortified. I was mortified. That was the day. That was it. That was my, impetus for change. So I do know how it feels to be morbidly obese. So let's show some compassion for these patients. Make sure that the bed is the right size. I show the picture on the left with the toilet because when we built the new building at Women and Infants, they had broken toilets coming off the walls because they didn't take into account that a lot of people are obese in general, and that also it's more prevalent in pregnancy. So they had to come up with toilet jacks that, if they have a patient that's been flagged as obese, then they come in and they put a special attachment in the bathroom. So let's do that as, not as obvious as we can be. So you're not going to go, hold the phone, let me walk in and put a jack under your toilet so your big butt doesn't break the toilet off the wall. Let's, be discreet and try and do this as compassionately as we can. So the right size device, the right size wheelchair. Understand that us as caregivers are at higher risk for injury if we try to remove these people too. So patient transfers require special devices and extra personnel. A nutrition consult, and you may be wondering why, even in a pre-op patient, why you would want one. A lot of obese patients may be obese but nutritionally deficient in many things. And a PT consult. So these PT physical therapists are experts at moving people, and they will help optimize mobility for even the most severely obese patient.